Good morning, good afternoon, and good evening. Welcome to today's discussion on the impact of climate change on maternal and newborn health outcomes, hosted by the Wilson Center's Maternal Health Initiative and UNFPA. The effects of climate change can begin in the womb, making it imperative that climate change and maternal and newborn health leaders work together to tackle climate change and improve maternal and newborn health outcomes globally. I'm Sarah Barnes, and I direct the Maternal Health Initiative at the Woodrow Wilson International Center for Scholars in Washington, D.C. Today's event is generously supported by UNFPA, the UN Sexual and Reproductive Health Branch. UNFPA and the Wilson Center's Maternal Health Initiative have a 13-year-long partnership focused on maternal, sexual, and reproductive health and gender equality. For those of you who are unfamiliar, the Wilson Center is a critical source of nonpartisan foreign policy research and analyses where we work to tackle global issues through independent research, open and honest dialogue like we're doing here today, and actionable ideas. Today's event is the second in a two-part series looking at climate change and population and is co-sponsored by the Wilson Center's Environmental Change and Security Program, which focuses on the connections between climate, health, and security, and the Wilson Center's Asia program, which focuses on human development, resource constraints, and environmental security in the region. In addition, we have had great support from our colleagues at the White Ribbon Alliance and are incredibly grateful to each of these contributors. We're hoping this series and others like it will generate necessary discussions in the lead up to COP27, which is the United Nations Climate Change Conference, which is starting in just a few days. Please send in questions if you're watching this today online that you want answers to better ensure that we're talking about what matters most and what can have the greatest impact. Questions can be submitted through the website chat function. The first event in this series was held last week and focused on climate change, population, and the shape of the future, and is a must listen for anyone grappling with the impact of climate change on people and what adaptations can be made to support populations, particularly women and girls. Today's discussion will focus in on the impacts of climate change on maternal and newborn health outcomes. We've got a fantastic panel of experts, some with a global focus, who will help set the stage, and others focus on a particular country or region. We have leading experts working in Pakistan, Indonesia, Mozambique, the UK, and the United States who will share their research and/or programmatic implementation and lived experience working in maternal newborn health, the direct consequences of climate change, and the need for adaptation in their particular country or region, or to address their particular topical focus. The discussion today is meant for the maternal newborn health community and the climate change community alike. One central theme from last week's discussion was the need to work at the intersection of climate change and maternal and newborn health, working across sectors together versus working in silos. Today's event is meant to be educational and informative about the concrete ways that climate change is affecting women, pregnant and postpartum people, and newborn health. We will also talk about successes and remaining challenges experienced or studied by our expert panel. Independently, climate change and maternal and newborn health are both massive areas of research, policy, and programming priorities, and each a global concern. Bringing maternal and newborn health and climate change together in one conversation is necessary to truly understand the long-term and generational impacts climate change is having now and will continue to have, unless significant and impactful efforts are made for generations to come. Research shows that extreme weather like floods, droughts, hurricanes, tornadoes, landslides, and mudslides directly impact women during pregnancy and the postpartum period, as well as the fetus, and can have lasting implications on child health. Extreme heat exposure, wildfire smoke, air pollution, changes in sea level and water saliency, and waterborne diseases also impact the health of a pregnancy for both women and children. Our experts will shed light on evidence and lived experience of how climate change can cause adverse outcomes such as miscarriage, preterm labor, preeclampsia, stillbirth, low birth weight, malnutrition, respiratory disease, shunting, kidney failure, hypertension, malaria, and other infectious diseases, as well as poor mental health. Additionally, studies have also shown that climate change is impacting women's mobility and livelihoods, as well as may lead to higher rates of child and early forced marriages. While to some may be seemingly unrelated, but I can assure you that women's empowerment in child marriage and adolescent pregnancy each have very direct implications on maternal and newborn health outcomes. Climate-related crises can also lead to diminished access to necessary sexual and reproductive health services, and individuals forcibly displaced as a result of extreme weather events face enormous barriers to access necessary health care. And finally, it's important to acknowledge the major inequities around the world as to who is most impacted by climate change. Research shows that in many cases, the people least responsible for causing climate change are the ones suffering the most from its effects. So we have a lot to cover in the next 90 minutes. And before I hand things over to our moderator, I wanted to thank UNFPA for their partnership, my colleagues at the Wilson Center for your support and guidance, and the White Ribbon Alliance for all your support and efforts, particularly in the production of a fantastic video from Indonesia on the impacts of flooding on maternal and newborn health, which we will share in a few moments. Post-event proper credits for all of those who worked on this video will be shared on our website. And a huge, huge thank you to each of our panelists and our moderator for taking the time to come speak with us today and for all the work you've already done to help make today's discussion particularly fruitful. And lastly, thank you to you, our audience, for tuning in today. I look forward to hearing from you in the audience-led Q&A portion of this event. So please put questions in the chat function on your screen, and we will work to address as many questions from the audience as possible. And now it is my honor and my pleasure to introduce our moderator, Paulina Ospina. Paulina is the Associate Director of Maternal and Child Health Programs at Direct Relief. Direct Relief is a nonprofit humanitarian organization that provides emergency medical assistance and disaster relief in the United States and internationally. She joined Direct Relief in 2009 with a background in public health and prior work experiences in the pharmaceutical industry and clinical research. Paulina works with underserved populations in healthcare settings in the United States, Africa, Asia, and Latin America. Thank you for joining us today, Paulina. The floor is yours.
Thank you so much, Sarah, and welcome to our audience to what promises to be an informative and interesting discussion today. Thank you also to the Wilson Center and UNFPA for facilitating this event on how climate change impacts maternal and newborn health. Climate change represents one of the largest global health threats to the 21st century, primarily affecting populations that have the least ability to adapt to climate change. Oxfam has reported that funding for disaster response has increased 800% in 20 years, and scientists predict that the severity and frequency of natural events will only increase. The subsequent resulting events, as Sarah mentioned, hurricanes, tornadoes, flooding, and droughts have already had a negative impact on public health. And pregnant women and newborns are increasingly being recognized as vulnerable populations in the context of climate change. As Sarah mentioned, I work for Direct Relief, a humanitarian medical relief organization. And for the past 70 years, part of the work of our organization has been focused on disaster and emergency response. At Direct Relief, we've seen firsthand how the severity and frequency of disasters is increasing. Whereas we used to respond to 1 or 2 major events a year, today we're responding to multiple large-scale disasters in a single year. Since August of this year alone, Direct Relief has responded to 7 hurricanes and cyclones across the Caribbean, Central America, the United States, and South Asia. We've responded to catastrophic flooding in the United States and the continuing ongoing tragedy in Pakistan. And we've responded to wildfires and extreme record-breaking heat waves in the Western United States. At Direct Relief, we've long recognized that women and newborns face special risks during disaster response. When populations are forced from their homes, because of climate, women and children face special vulnerabilities and face increased risk as gender-based violence, child marriage, trafficking, and lack of access to health systems as those systems become disrupted. Last week, I corresponded with our Direct Relief team in Puerto Rico, who has been working on recovery efforts since Hurricane Maria made landfall in 2017. Since then, the effects on maternal and child health have been well documented and include lack of adequate access to pre and postnatal services and increased risk of preterm birth and miscarriage. And in September, the team again responded to a hurricane as Fiona hit as a Category 4 on the island. And once again, we saw disruptions to maternal and newborn health. After Hurricane Maria, the island saw a large exodus of medical professionals from the island, which resulted in delays to specialty care. After Hurricane Fiona, those delays were further exacerbated, and today we see a 6 to 9 month wait list to be able to access specialty services. We know that in this context, pregnant women tend to miss antenatal care. This is just one of many examples of how extreme events related to climate can affect access to services and subsequent health outcomes. But I think it's important for us to realize that responding to climate change may not always be in the context of natural disasters. As we see sustained droughts and heat waves, these kinds of events may not have an acute beginning and an end. It may not be an acute event, and therefore becomes more the norm of our everyday. And as such, I think it's especially important for us to understand how climate change affects vulnerable populations, and especially women and children as part of that. Today, we have an excellent panel of experts with expertise in academics and special regions that are affected by natural disaster to help us tease out and understand how climate change affects maternal and newborn outcomes. I think that for us as a global health community, understanding how we can best respond to climate change is important, but also to understand our response in terms of preparedness and mitigation. So I'm excited to have a conversation today with our panel. I hope that you are as well, and to learn so many of the things that intersect between climate change and maternal and newborn health that we sometimes just simply aren't aware of in our specific areas of study. So joining us today, we have Sari Kovats, an associate professor in environment and health at the London School of Hygiene and Tropical Medicine. She is the co-lead of the Belmont-funded Climate, Heat, and Maternal and Neonatal Health in Africa Research Consortium. We have Talib Lashari, who's a technical advisor in the Population Welfare Department with the government of Sindh in Pakistan. He is also working as a consultant to the Department of Health and is a former advisor to the Health and Planning Commission for the government of Pakistan. Joining us from Indonesia is Nila Wardani, the coordinator of research division for the White Ribbon Alliance. She works as part of a local NGO with rural women's empowerment, including the prevention of child marriage by building leadership among young women and girls. We have George Mantini, who is the director of IPAS Mozambique. George has a wealth of experience in the fields of research and sexual and reproductive health. He has a special interest in the intersection of reproductive rights and climate change, and leads IPAS's work in Mozambique on this issue. And to round out the panel, we have Skye Wheeler, a senior researcher in the Women's Rights Division at Human Rights Watch. Skye works to highlight how the climate crisis and other environmental degradations worsens reproductive health rights and existing inequities, especially for pregnant people. Skye's previous work focused on sexual violence and the obstruction to sexual and reproductive health care and conflict and political crisis. She's also a former journalist. So before we jump into the discussion, I want to reiterate what Sarah said to please include your questions in the chat box. You can find that on your event webpage just underneath the webcast video. We'll circle back to questions after we answer a couple of questions with our panel to set the stage. And to do just that, I'm going to start with Sari. I'd like all of our panelists to be able to speak to both the direct and indirect consequences of climate change and how climate change and extreme weather intersects with maternal and neonatal health. And so, Sari, I'm going to hand it over to you to get us started.
Thanks very much, Paulina. Very happy to be here. So I'm just going to present a few results from our CHAMNA project, primarily focusing on some epidemiological research, evidence reviews, and some qualitative research we've been doing in Africa as well. But I just want to make two comments about heat, because I'm primarily focusing on heat effects on maternal and neonatal outcomes. The first is it's not just heat waves, it's basically hot days. So the impacts are not just focused around particular identifiable events. So this general increase, and everywhere on the globe is getting more hot days. All of this are increasing our risks from these heat effects on our health. And secondly, that we have to think about the future as well. So high temperatures are going to be increasing everywhere, and perhaps nearing some of our physiological limits. In some places are going to become extremely hot. But we have to consider not just the temperature or the climate hazards, but also the other factors that help that increase, or well, I should say improve maternal and neonatal health. And also factors that undermine maternal and neonatal health. So it's not to look at these climate risks in isolation. We must look at the other factors that cause disasters and heat risks as well. So just to give a quick overview, because I have very little time, we know that high temperatures increase the risk of preterm birth. We've seen this in nearly all populations, although we may not understand the mechanisms, the physiological mechanisms by which high temperatures trigger sort of an early labour, because there's obviously been very little research on pregnant women. It's unethical. But we do know that there's a very strong relationship with preterm birth, which is important, of course, because preterm birth is a major cause of neonatal mortality and for lifelong impacts on children. We know that high temperatures are also tetragenic, I can't say it, but it causes birth defects. So when the mother's temperature is very high, near 40 degrees, in fact, she's experiencing heat stroke, then it increases the risk of congenital defects, including heart defects and so on. But we're also very interested in looking at just maternal outcomes rather than the birth outcomes. And we know that heat and high temperatures also increases the risk of several serious maternal outcomes, including preeclampsia. And the impact on preeclampsia is thought to be high temperature exposures in very early, in the first few weeks of pregnancy. So consistent with some mechanism that involves the placenta, because we know that's involved with the risk of preeclampsia. And of course, preeclampsia is a major cause of maternal mortality. But other maternal outcomes that may possibly be affected by high temperatures include gestational diabetes and also infections as well, and possibly some mental health outcomes based on analyses of hospital admissions. So the less kind of direct effects of heat, we know a lot about how high temperatures and also changes in humidity increase the risk of transmission of infectious diseases. And there's several infections that are of concern to mothers and babies, including strep B. So bacterial infections are particularly affected by high temperatures, but also vector-borne diseases, and maternal and pregnant women are very high risk of certain vector-borne diseases, including malaria. We know a cause of maternal complications. So there's quite a wide range of outcomes that are affected. And as I've said, the impacts, high temperature can also have impacts on well-being. You know, it's unpleasant. It can be very unpleasant to be hot, and it can add to additional stress with pregnancy. So some of the qualitative research, you know, with mothers and caregivers and also health workers have focused on how it adds extra stress to pregnant women, particularly if there's also a drought ongoing, which we know is happening in Kenya at the moment. So they have less access to hygiene, you know, they're less access to water to cool down. But high temperatures may interfere with exclusive breastfeeding, because we know that mothers, if it's very hot, it's uncomfortable to breastfeed, it's uncomfortable for the mothers and for the babies. And anything that reduces the time with exclusive breastfeeding also has negative or health implications for the newborn. But it may also interfere with skin to skin care as well. And also of concern is that very high temperatures may affect health-seeking behaviour. So women may be less likely to access antenatal care as well. And finally, we have a lot of understanding of the physiological risks for newborns. Newborns cannot thermoregulate. They're relying on carers to keep them cool and also to keep them warm. You know, there's a risk from cold. So we know that high young babies have very high risks of heat-related death. But we don't have a lot of evidence regarding this. So it's actually quite difficult sometimes to quantify these heat risks. You need quite large data sets of outcomes in order to detect the heat risks. So just to say that there's quite a big gap in our evidence. Thank you.
Thank you, Sari. I appreciate you doing a summary of some of the research that is currently available. And I know that we'll talk more in detail about some of the regional consequences that we're seeing from some of our panels. So I'm going to turn it over to Talib, who has been at the forefront of experiencing some of the most catastrophic flooding in the country of Pakistan. Talib, I'll hand it over to you, please. And just a reminder that you're on mute.
Thank you so much for reminding about the unmuting. Thank you, Paulina. I think today is a very important topic that we are going to discuss, and it's very pertinent. After a few days, I mean, on 15th of November, will mark the population of the world as 8 billion, as per UN latest UN report. And mostly now people know that what is the climate change and what are the effects of the climate change on the lives of the people. We know it's a long-term shift in the temperatures and weather patterns across the globe. And till 1800 century, it was mostly the natural shifts in the weather patterns. But after the 1800 century and onward, we have been seeing the fossil fuel burning, and especially the oil, gas, and other fuel like coal, that's creating devastating impacts on the temperatures. According to international intergovernmental panel on the climate change of the United Nations, the overall global warming is at 1.1 centigrade nowadays, but it's fast moving towards 1.5 centigrade. And that warming means intense temperatures and worldwide very devastating consequences like floods, severe droughts, cyclones, forest fires, and so many other consequences like sea level increase. So I think these are some of the consequences of climate change that we are even witnessing now. In countries like Pakistan, we have very recently, and we are going through the devastating effects of the rain floods that started with the urban flooding, then moving to rural parts of Pakistan, whereby 1/3 of the country was submerged since June this year, and still we are struggling to rehabilitate the people. There has been 33 million people who have been displaced. Only in the province of Sindh, 11 million people were displaced, and 7 million people have to, get the shelter at the camps and roadsides, whereby they could find some shelter. Most vulnerable in this situation have been women and children. And there have been more than 800 deaths, and 61% of those deaths were women and children. So we can see that the consequences are more for the women and for the children. It's now, there's a lot of evidence now available for the past 1 decade or so that the impact of the climate change on the maternal and neonatal health outcomes are direct as well as indirect. Like just now, Sari also mentioned that the heat waves that occur in most part of the world, especially if we look at the temperatures in Pakistan, in Sindh, we can see in the summers, it's 50 centigrade or 55 centigrade, which is unusual for the past decade or so that it's happening. And that heat wave, when occurs, it has direct consequences for the pregnant mothers and the fetus, and that can become preterm birth, and that preterm birth will be definitely underweight baby, and it's also very dangerous for the mother and her health, as well as the preterm birth results into stunted and wasted newborn baby. So if we talk about the indirect consequences, we can see that in long-term consequence of stunting is there, malnutrition is there, not only for the child, but for the mother as well. Also, there are the cognitive abilities, dysfunctions in the long term on the health of that child, and the severe malnutrition for a woman which goes through this this kind of labor, which is preterm labor. In Pakistan, the southern part like Sindh and the western part like Balochistan, and some part of the Punjab like South Punjab and Rahim Yar Khan, these have been categorized under the climate change as severely affected areas. And in these areas, the fertility level is also high, from 4 to 5 children per woman. And also these areas are having more, poverty level and less education level. Therefore, the consequences of the climate change also occur in that way, that we can see that these severely affected areas are already deprived areas. So we can also see, due to the poverty level in those areas, the consequences in terms of gender-based violence. Gender-based violence comes up with the climate change devastations in case of when there's no shelter, in case of when there's no drinking water, and there's no proper hygiene. The families come under pressure, and that pressure mostly comes on the women and the girls. And recent survey that has been conducted by multi-sectoral stakeholders on the need assessment in terms of health, it has been shown that the 50% of the women and 48% of the girls are vulnerable to violence, mainly the gender-based violence in flood-affected areas. So these are some of the direct and indirect consequences of the climate change that we have to look into. So I'll be focusing during my discussion today, one of the paper that we have developed on the climate change in terms of resilient development of the resilient health system, climate resilient health system. So MNCH is part of that climate resilient health system that we need to develop, but definitely we will look into the multi-sectoral nature of climate change, because it's not the one sector that is affected. After all, the health sector is at the receiving end, because consequences in each and every sector are finally landing into the health sector, whereby health sector has to respond in terms of services, in terms of policies, in terms of programs. So I think that kind of data, which is mostly secondary data, that I will be sharing today.
Thank you, Talib, and we'll certainly come back to you to hear more about what those specifics have been as we continue the discussion. And we'll turn now to Nila for another regional perspective for Indonesia. Nila has a video to share with us, and Nila, could you please set that up for us?
Thank you, Paulina. Thank you for this event to Wilson Center. Yes, like other panelists mentioned, Indonesia is severely impacted by climate change, rising temperatures, sea level rise, and soil erosion. Climate-related disasters such as flood, landslide, wildfires, and droughts. Communities living at or near the coast are most at risk. Among them, pregnant women and newborns are most impacted by climate change. A sea level rise, for example, has direct impact on pregnancy. It changes salinity of water due to seawater intrusion. The increase of salinity will increase salt intake that can have adverse effect to pregnancy, leading to increase of hypertensive disorder. I would like to share the evidence from our explorative research by showing the video. This is the video.
Saya lahir dan besar di desa dekat pesisir pantai di Kabupaten Malang ini. Selain sebagai ibu rumah tangga, saya juga aktif sebagai kader desa. Desa kami telah mengalami perubahan yang nyata. Sejak terjadi gelombang pasang atau banjir di tahun 2019, desa ini mengalami rob hampir setiap tahun. Meski tingkat besar, tapi air laut bisa naik sampai ke perkampungan. Desa saya ini dulu dikenal dengan hasil ikan dan rumput laut yang melimpah. Selain sebagai sumber pendapatan keluarga, juga sebagai pangan untuk keluarga bagi masyarakat setempat. Dalam 5 tahun terakhir, tidak ada lagi rumput laut. Bahkan ikan sudah sangat sulit didapat. Kalaupun ada ikan, hasilnya sangat sedikit, dan masyarakat memilih menjualnya daripada dikonsumsi sendiri. Dulu ikan menjadi salah satu sumber protein pangan untuk keluarga. Dulu masyarakat di sini biasa makan ikan. Nah, tapi sejak saya menginjak dewasa dan menjadi ibu, pola konsumsi keluarga itu berubah karena ikan sulit didapat dan menjadi mahal. Jadi sumber protein keluarga berubah ke tempe, tahu, dan sesekali telur. Mungkin dengan pola yang seperti ini itu bisa mempengaruhi daya tahan tubuh, terutama untuk ibu hamil dan anak-anak.
Di sini kan karena udara panas ya, makanannya juga kurang bergizi, jadi ada sedikit suka darah tinggi ya.
Itu ibu hamil juga termasuk ya, Bu ya?
Ibu hamil, darah tinggi, terus sekarang mah banyak penyakit gula darah ya, jadinya apalagi kalau darah tinggi melahirkan juga susah ya.
Disesar.
Kudunya disesar ya.
Iya,
gitu.
betul.
Ya itu begitu, jadinya ujung-ujungnya jadi prematur.
Oke, lahirnya kejadian prematur.
Karena darah tinggi
Nggak boleh
disesar. Iya.
Kalau yang punya BPJS.
Kalau enggak jadi masalah. Di kampung sebelah itu sekitar tahun 2017 tuh pernah kekeringan yang cukup panjang, hampir 6 bulan. Jadi sulit untuk mendapatkan air bersih. Kondisi ini memberatkan perempuan, karena terutama ketika perempuan itu menstruasi, karena kan harus sering membersihkan alat reproduksinya. Sehingga kalau kesulitan air seperti ini, maka menyebabkan ini alat reproduksinya gatal dan bisa menjadi bau kan.
Thank you so much, Neela. It's so important, I think, to hear directly from the perspective of women. There's so much to tease out in that video, from potable water to food insecurity to menstrual hygiene, that merits a whole discussion in and of itself. So I hope that we'll be able to come back and discuss a little bit more of those topics. But for now, I want to do another regional perspective, going to Mozambique, this time to George to talk about his work in the area. George, over to you, please.
Thank you. Thank you for inviting me to contribute to this discussion. I'm very passionate to talk about the intersection between climate change and reproductive health. We understand that climate change disproportionately bear the brunt of women and girls, and we know that women and girls are more vulnerable to the impact of climate change because they lack power. Ultimately, climate crisis deny women the ability to control their own fertility and on their own lives. Between 2020 and 2001, IPES conducted collective research in Zambezi, Mozambique, and Khulna in Bangladesh. We wanted to understand how women's experience with climate change impact their sexual and reproductive health decision-making, behavior, and other outcomes in the cyclone-prone community. Mozambique and Bangladesh are both highly vulnerable to cyclones and flood.
So I think George's video has frozen. There we go. We'll just wait a second.
Making them among the countries most severely impacted by. Can you hear me?
George, we're getting a little bit of an interruption in your video.
Yeah, but now can you hear me?
We can, yes.
Okay, thank you. So because it's raining here, heavy rain, that's why the internet is a bit unstable. But I'll continue with my presentation. So we wanted to understand the intersection, and we understood from our study how the climate events exacerbate poverty and poor health outcomes for rural and coastal population. I would like to share with you what is the key findings of the study in both countries. First of all, what was also important to know that climate change disproportionately impacts women and girls by exacerbating existing gender inequality, disrupting access to sexual and reproductive health care, reducing the already limited economic opportunities. We also find out that climate change directly and indirectly affects women's contraceptive use, fertility intention, pregnancy outcomes, and gender-based violence, the economic roles, and sexual health. The time before or during and after extreme weather, such as cyclones, is when access to care for contraception, pregnancy, and abortion is most compromised. We also, from the research, as a result, we find out that pregnant women are particularly at risk due to climate change, facing increasing risk of miscarriage, early labor, pregnancy complications that could lead to illness, injury, and death. The girls were evidence that it's increased risk of sexual and gender-based violence, child marriage, early sexual assault. And one also was very interesting on this for the work we could do as IPES and other stakeholders in the area of climate change. So we understand that women play a leading role in helping families and communities survive extreme weather events, adapt climate change, but the opportunity for women participation in climate action decision-making bodies is insufficient. especially at the leadership level. We find that at the leadership level for those groups that manage the humanitarian response, women is not represented. But the 5 recommendations came from our study. Women said we need to increase women's opportunity for paid work, so they don't have to resort to jobs that risk their health and safety. This is more connected with sexual violence, because then they really depend on those food to survive. So there's an exchange of sex example. They want
So George,
we to consider women's needs during and after climate change. Yes.
Sorry, I just wanted to let you know that we're still experiencing a little bit of connectivity with your connection.
Okay, so I will finalize now. There's also very important discussion where women would say they expect that during those events we will be more not only focused on survival, but also making sure that the climate change it's also affecting the sexual and reproductive health, and also because in this region there's the poverty has been linked to gender inequality. So we need to tackle issues of poverty. If you don't tackle issues of poverty, the climate events exacerbate those inequalities. So thank you.
Thank you so much, George, and thank you for powering through some of the technical difficulties with the connection. I think that we were well able to get the salient points of what you were trying to get across, so thank you. And then Sky, we're coming to you. I know that you've been doing some interesting work in very varied settings from what we've been discussing, so over to you to hear some about what you've been working on.
Oh yeah, thank you so much, and amazing to be part of this panel. I thought I was going to be in listening mode, but I've been making lots of notes. So I mostly work here in the US, and the 2 key points that I have really found in the research that we've been able to do here is that the climate crisis is not only driving inequalities and inequities between countries, but also within countries, and that there's far too little happening to address this. And what we've really found in our research is that the climate crisis is driving what frontline communities and reproductive justice leaders here in the US, mostly women of color. The reproductive justice movement was established by women of color here in the US, Black women in particular. But they've always known this, but it's really driving us to understand that a healthy environment is really a core component to the right to sexual and reproductive health and rights. So I've really been looking at the impact of extreme heat on the maternal health crisis in the US. So just for those of you who don't know, the maternal health crisis in the US has 2 very salient points. One is that it's getting worse. Unlike other developed countries, maternal health is going in the wrong direction in the US. And the second most salient point about it is that it's really marked by very big differences between outcomes for white women on the one hand and women of color, especially Black women, on the other. So I'm a white woman. I live in Washington, D.C. I am less likely to die in childbirth here in D.C. Than anywhere else in the US as a white woman. But if I was Black, I would be 3 times more likely to die in childbirth in DC than the national rate of maternal mortality. Preterm birth is twice as bad for Black babies than white babies, and that's the same with low birth weight and for infant deaths. So this is, of course, a result of historical and current racism here in the US, and an unjust health system that doesn't work for low-income people. So what we have here in the US is a perfect storm for the climate crisis to worsen already existing injustices and inequities. As Sari and others have really expertly described, we know that there are links between extreme heat and preterm birth, low birth weight, and stillbirth. The studies that have been done here in the US, and there's been a pretty significant number of studies, when they disaggregate by race, you see a bigger effect time and time again on Black women than white women. This is not surprising. We have greater exposure to extreme heat for Black communities in the US. Studies that have looked at extreme heat in cities have found in multiple urban areas that Black neighborhoods are hotter than white neighborhoods. This is because they have less trees, more concrete. We also have worse housing for poorer Black communities than white communities, less AC. Work is also another place where exposure is very different. Low income work, or very hot work, tends to be low income work. And in the US, we have a very poor protections at work for pregnant people. So for example, even the right to have a water bottle on my workstation or extra bathroom breaks so I can drink more and stay hydrated when I'm pregnant, those rights are not protected in the US federally. And then we also have greater vulnerability, greater rates, for example, of diabetes, cardiovascular ill health, and we know that extreme heat makes people with these pre-existing conditions more vulnerable. I've also been lucky enough to do interviews about wildfire exposure as well here in the US, talking to midwives, doulas, and other birth workers who are really worried about how wildfire smoke and stress and displacement is worsening, again, inequities. We know from the epidemiology that wildfire smoke is associated with preterm birth, low birth weight, and also some birth defects potentially. And we also, but what's not clear actually from the epidemiology is how much is to do with the horrible air, the particulate matter and other chemicals in the air, which we know from air pollution studies are very bad for pregnancy health, and how much is to do with stress. This has really come across very clearly in the research, how stress, worry, anxiety is playing a very big role in the wildfire exposure here in the US. And for some populations in very distinct ways. For example, indigenous communities in New Mexico have been saying in interviews about how loss of precious forests that have particular emotional connections or historical cultural connections is very re-traumatizing for communities that have already lost land because of the US's history with indigenous people. And then again, with wildfire smoke, we're seeing that while there is much greater awareness from public health that wildfire smoke is bad for pregnancy health, the advice that's given is not very actionable if you are low income. So the advice is to leave the area, but of course, who can leave? We have situations in Oregon, for example, where we've seen hotels jack up prices in smoke-free areas. So a family that's very low income is barely managing to get food on the table every month, then has to spend hundreds of dollars on a hotel, and sort of the long-term impacts of this. And we're also seeing, and this is something that colleagues have already mentioned, that we're seeing double or triple climate impacts. So low-income housing, no AC, so people open their windows when it's hot, and so the wildfire smoke comes in, people having to make choices between wildfire and being too hot, both, as colleagues here have said, very bad news for pregnancy health. So I'll leave it there, but looking forward to talking more.
Thank you, Skye. It's good that you brought up wildfires. We haven't discussed that today, and that brings its own particular set of issues for pregnant women and newborns. So thank you for bringing that up. So as we go into our second set of questions, I'd like for us as a panel to discuss some of the successes and challenges, but also some of the interventions that you've been doing in your regions or as part of your academic work to try and mitigate some of these consequences. And if you can keep your responses to about 2 to 3 minutes, we want to be sure to have some time left at the end for questions from the audience. So sorry, I'm going to kick it back to you to lead us off for this second round to talk about some of the work that you've been doing in your area of research.
Thank you, Paulina. So I'm just going to talk about some of the interventions that we kind of developed within the CHAMNA project. So this is with our colleagues in Kilifi in Kenya and in Burkina Faso in West Africa. Overall, there's quite a lack of evidence regarding interventions to respond to heat. There's sort of a lot of understanding about how to cool houses, and in that case, the barriers aren't really a lack of evidence. It's to do with the lack of finance, a lack of will, a lack of governance, how to address making sure housing quality is good and it's fairly distributed. But there's a lot of focus around behavior change, and it's quite important to communicate risks well, but it's not sufficient to communicate those risks. Heat isn't often well understood, particularly if you've been living with heat for a very long time. It's very normalized. So there's a lot of work to be done so people understand that some of those heat risks are, risks to their health or their baby's health, and how to formulate messages and advice so that the health is protected. So we've been building on the qualitative work that has been done. There was also a lot of investment in co-design, so meetings with mothers, meeting with caregivers, meeting with local health workers and other kind of senior health and local leaders to engage them with the process and develop the intervention with the groups. And this is primarily with rural populations. So they're being evaluated. They've just been evaluated in the kind of heat seasons this year, so I don't have any results, but we have developed some tools for communicating heat risks with mothers that we hope to be able to share that information shortly. Thank you.
Thank you. Sorry, I know that those kinds of research and interventions are so important just because there is a dearth, as you mentioned, on research on this topic. And so all these data points, as we continue to collect them, are going to be beneficial to global community at large. So Talib, I'm going to turn to you now. I know that you've been working on the flooding for months now, and we've seen projections that the flooding is not expected to recede for another 6 months. And so there's just a lot of work that is being done in the area related to flooding in Pakistan. Can you talk about some of what you've been seeing in terms of interventions to help mitigate some of these consequences to health outcomes for moms and newborns?
Thank you, Paulina. As you know, this has been one of the most devastating floods in Pakistan, especially in southern and western parts of the country, Sindh province, starting from urban flooding in Karachi, capital of the province, and then rural terrain and hilly parts of the Balochistan. Basically, the IDPs have been in thousands, and the people displaced in millions. Around 1 million pregnant women have been living in the IDP camps, which were under the open sky and in the tents. A lot of work started through the Government of Sindh, Department of Health, and also United Nations Fund for Population, WHO, and other NGOs like HANDS, Pathfinder. They started supporting people, Green Star, and also the philanthropists. They have been very active during this entire process. we have seen that the family planning needs of the women could not be fully satisfied because of the disruption in the services. According to recently conducted need assessment, it shows that more than 20% women are having access to family planning. And that was during the COVID even reduced to 44%. Although the government of Sindh and the Population Welfare Department did its best to provide the family planning services and restored the services. We introduced family planning and reproductive health guidelines during the COVID. We have also introduced the Siana Press DMPA SC, which is a new method which can also be a self-care method. So that is under, we are doing a pilot on the Siana Press, whereby selected women are going through self administration of the Siana Press. But very soon we'll be scaling up the Siana Press in the entire province of Sindh to roll out plan. We have also seen during this process of rescue and this process of rehabilitation that the reproductive and maternal health needs have been within the 5 most needed health needs. At the top, we all know that medicine, then mobile camps were required. Thirdly, it was child health, because every family wanted to first provide health care to their children. Maternal health and reproductive health were also at the 4th level, and immunization of the children. So these, and then top 5 needs included food, health, medicine, tents, and water. These were the 5, because all these are very, very closely related to livelihood. So this kind of data that we have been looking at, and continuously there have been we have seen this vector-borne diseases and waterborne diseases like malaria and dengue. There was rise in malaria and dengue, and initially there has been rise in cholera as well, and gastroenteritis. And the female and the girls were more vulnerable during this process, because these have less protection in this situation. So we have seen that these vector-borne diseases and waterborne diseases raised at a level, and then through mitigation measures and through interventions of the Department of Health and development partners, these trends have now been receding. And now we are moving towards rehabilitation, whereby people need resilient behaviors, and also we need to rebuild the houses, and we will be now moving to that, and we are engaging with the partners in a public-private partnership mode to rebuild the lives of women and children.
Thank you so much, Talib. And I'm so glad that you brought up the issue of family planning. We know that women in times of emergency and economic uncertainty want to curb their fertility, but yet that is precisely the times when access to family planning services are disrupted and really challenging. So something I think for all of us to keep in the forefront as we think about mitigation of these types of issues. Nila, I want to turn to you in Indonesia. This very powerful video that you showed us, I'm really interested in hearing what you've been doing in your community to try and address some of those really just incredibly difficult issues.
Yeah, thank you, Paulina. Actually, in Indonesia context, there are already some institutions that built by the government to handle or to address the issue of climate change and environmental disaster, but mostly focus on the environmental issue as well. Only, I mean, like planting the mangrove, it's very little what the effort or policy that related to the health issue, especially for women issue. This very little attention from the government. We have to continue a dialogue with all the stakeholders actually, especially at the national level and also at the community level. We have to educate them using the existing system that we have, like community health center, things like that. What's actually the impact that they feel, that they experience from the climate change? We consider that according to the discussion with them, they consider that climate change impact to the health, especially for women, is something new that they have to understand better, because it's like the long-term, the long-term what the impact that they can feel and understand better. So they need more education at the field level for the community, especially using the system that we have. And at the national level, we continue advocacy and dialogue with the policymakers. For example, the Ministry of Health, how this climate change has a severe impact to the health, especially for women, pregnant women, and children. And why in this research we concern into the coastal area? Because Indonesia, as you know, is the biggest archipelago that have like 100,000 kilometers of the coastal line. And according to the research as well, that would be, about 23 million would be affected for this in 2050 because of the damage of coastal ecosystem. So it's still a long way to go for Indonesia to build the understanding of this issue is urgent for all the stakeholders. Thank you.
Thank you, Nila. And then George, turning over to you in Mozambique, I know that you and your organization have been really focused on reproductive health rights, and interested to hear what some of your interventions and successes have been as it relates to this topic.
Yes, thank you. I would say that the work that we've been doing in the last term, after the research, first of all, we did bring all government stakeholders to discuss the results of the research. And important finding was how to integrate or to respond to unmet needs of sexual health during the climate events. And that led to design a standard, guidelines on how to respond to humanitarian, example, or climate event needs, having there included the unmet needs for sexual health. I think the important was how to respond, example, to commodity security. We see that during floods, women are isolated, and you need to secure family planning and self-help commodities on those facilities. So you make sure that you plan in advance those facilities that are at risk for any floods around, or the road will be closed. So they could have the commodities to security of this commodity to still serve the women. And also, I think the very important topic also was we have to include the training package for humanitarian response, the value clarification regarding, example, the needs of women in terms of safe abortion, in terms of contraception. And that is very important, because one of the institutional barriers you see is the humanitarian workers or the public sector, the police, which is not sensitive. It doesn't understand why you need to make sure those services should be available 24 hours. And women should be moved to have access to health centers, even during those under shelters. So it's also not only provide information and training, but also create a package, an integrated package that also will empower those champions, because they are champions in public sector who really understand that you need to include that. Also, I think there is there is a disproportionate resources in humanitarian response that focus more on surviving and less on reproductive health needs. I think that is something that we need to change. We need to revise those responses. We need to be more integrated. And it's sad because if you see in all climate events, it's a women and girls face there. So it's very unfortunate that even that we see those faces, we're not able to respond to them. We're not to design the program that really respond to the needs of women and girls. So that is a really important important to understand. Another I think important issue here is that how climate change is exacerbating the poverty or the gains that we had many years ago. Example, in Mozambique, the flood and the last cyclone, it just destroyed schools, which, you know, we've put a lot of effort the last 20 years or 10 years to put girls in school. So when the school, to build a new school takes another 10 years. So it means we'll have a generation of girls without education, which was a powerful movement in the world to make girls stay more time in school. So I think we need to think about how those climate events are really jeopardize all the gain that we got in the last years in terms of, you know, having more girls at school, moving from poverty conditions as well, extremely poverty, to a better access to health services that now undermine because of those climate events. So I would say this is what we need. We need action, and I sense understand that. And then you can't do a program that responds to climate events without really looking about how this is undermined all the gains of the last 20 years for countries like Mozambique, Bangladesh, and other countries which made a lot of effort, you know, to build schools, build hospitals. And today, example, Idai was 3-4 years ago. We still not having built new hospitals and new schools. So the girls are not having schools, they're not having health centers, and women, they have to, you know, they have to find other informal. So you have a lot of unattended pregnancy, which means also unsafe abortion, which led to most of maternal mortality. So all those reductions that we're doing in maternal mortality, the climate change and climate event is just jeopardizing that. So I think the action is needed. We need to see, and the connection is there. I think the research, it shows, but also it's a lot of real connection. If you just visit those areas and speak with women, it's there, the connection, how it's impactful, how these really climate events are really changing the life of people, not to better, but to worse.
Thank you, George. Yeah, I think you're exactly right that we need to be thinking about how these long-term gains that we've made over the last few decades are being rolled backwards with events like climate change. And I think with COVID, a lot of that conversation is now more salient in people's minds, and we need to include climate change as part of that thinking and conversation. Sky, what about you and what you've seen in terms of your work?
Yeah, so I think here in the US, one very good thing, I'll mention two very good things. One is that we're seeing much better awareness that one of the most important ways that the climate crisis is going to smash and worsen inequity and injustice in the US is going to be on human bodies, on human health. So I think there is growing awareness of that. However, maternal health and newborn health, especially maternal health, but also newborn health, is really missing from the conversation. And I think this is something that others have touched on before, is that these terrible silos we have with environmental and maternal health, both very strong movements in the US, but not enough bridges between them. I mean, for example, we're still seeing cities and counties and states write climate action plans with no input from reproductive groups or pregnant people. We did a review of some 150 documents, climate or heat awareness plans or climate plans, and we found pregnancy mentioned 2 or 3 times, and the threat of extreme heat to pets, to dogs and cats, came up 37 times. It's changing. Things are changing, but not fast enough. And I'd say that, there are very good reasons why the maternal and reproductive health space is overwhelmed in the US. We have increasing rates of maternal mortality, increasing rates of preterm birth, terrible racial inequities. We've also just lost the constitutional right to safe abortion care here in the US. Total catastrophe. So the sexual and reproductive health movement is constantly battling crises here. And the climate crisis is just one more of an already vastly overstretched community. Some things that could be done is, one is we could, the Environmental Protection Agency here in the US the Biden administration has put a big focus on environmental justice. They need to start pulling in reproductive justice experts into that space. And the second very good thing I wanted to mention is that on the front lines, the communities that hurricanes are crashing into, communities that are seeing vast tracts of land burned to the ground in wildfires, extreme heat, the frontline health workers, the doulas, midwives, and others are already putting stuff in place to try and protect pregnancy health. They're doing the work. But the question is, we've now had like a big climate bill passed here in the US, billions of dollars, but is that money going to get to those frontline health workers? And that's a big question. It's great to see, we're seeing them do the work. It's really exciting, but are they going to be properly resourced over the next years in order to be able to protect pregnant people and newborns?
Thank you so much, Sky. So at this point, we want to open it up to questions from the audience. I would encourage everyone, if you haven't already, to add your questions to your chat at the webinar page so that we can view some of those questions. We've already gotten a couple, so I'll throw these out to the panel, and I'll encourage anyone on the panel who has experience or expertise on the particular topic to please jump in and help answer. And Sky, you touched on this a little bit, talking about midwives and doulas as first responders. I think that's really important. We don't often think of them as first responders in disaster response, but they actually are, because they're embedded in their communities. And we do have a question here regarding how the role of community health workers, in addition to health providers like doulas and midwives, what role they play in identifying the impacts of climate change in maternal and newborn outcomes. And I'd also like the panel to think about mental health in this context for pregnant women in disaster and climate extremes, and how community health workers and first responders can try and help mitigate some of the mental health issues that we know come up for pregnant women during these time periods. If any of you have any experience in these particular fields, please jump in.
May I say, Paulina, regarding the community workers?
Yes, please.
In this, flood emergency situation, the role of the community workers, that includes lady health workers in Pakistan, particularly in Sindh province, we have 22,000 lady health workers, and community midwives. These are also in few thousand numbers. The problem is that if you have uncovered areas, I mean, not every area is covered by the community workers. Due to lack of qualified staff, you don't have that level of qualification, sometimes due to low literacy level, and then there are challenges of trainings. So 48% of the population in the rural Sindh is covered by the lady health workers, community workers. In this situation, we have witnessed that in the flood emergency, the number of home-based deliveries increased. And even the induced abortion, I couldn't mention earlier, but that there are cases of induced abortion. And that also, needs safe delivery kits, especially in terms of home delivery. and a very important coverage by the community workers. So the government and the development partners together, they have been trying their best to reach to the communities, and where the community workers were lacking, we have been having the medical camps, mobile medical camps, whereby medical tents were put up, and women doctors, they were placed in the mobile camps, and they provided these services. But you know, the backup support is required. Once the mobile camp leaves the area, you need to fulfill the follow-up kind of activities which women and children and girls need. So we have been trying to provide hygiene kits, dignity kits, and self-delivery kits within the communities, and the community workers. We are trying to work with the development partners to train community workers into the emergency situation. Although we have trainings during the COVID-19 situation, because every country in the world have been going through this experience. So we have a number of trainings into the emergency situation. So that kind of training also is working. But the important thing is that what we are going to do about the uncovered areas. So we are working with the World Bank and Islamic Development Bank to work on a human capital project that is especially designed for the 20% of the lowest quintile in the province of Sindh, which is mainly in desert, in delta, in hilly areas, in riverine and arid zones, and peri-urban and slum areas of the province. So through that project, we are trying to develop community health workers in the community where lady health workers are not available. We'll be filling in through CHWs. These CHWs would also, although not be at the level of lady health workers or community midwives, but they will be mobilizing the communities who are even more vulnerable, and they have been facing these challenges in the flood emergency. So these communities will be provided support through CHWs. So this is how we are going to mitigate the flood emergency situation.
That's amazing to hear, Talib. I think community health workers are the first entry point for most women for their own health and their family's health, and making sure that they're well equipped and have good community coverage goes a long way into ensuring population health. Is there anybody else who would like to comment on that? Sorry.
Yeah, I just wanted to stress the importance of educating community health workers or training, also nurses and midwives around heat risks as well, because it really isn't something that appears to have been covered sort of previously. So I think the knowledge translation for a lot of these emerging research that's coming out on heat risks, but also around sort of other extreme weather, is really important. And it's not just around extremes or disaster situations. You know, many populations experience high temperatures every hot season. So it's important to sort of embed it so that it's routine, it's within clinical practice and within clinical and other training materials as well. And I think WHO and other kind of partners are also interested to support this.
Thank you, Sari. And actually, you touched on one of the questions that we received regarding the seasonality of climate change, and what research or work is being done to either predict when extreme weather is going to occur or likely to occur, and whether there's any education or guidelines or recommendations for women wanting to be pregnant around when is best to be pregnant during to try to mitigate some of these events. So I don't know if anybody else has anything additional to say in respect either to the community health workers as we've been discussing, or to this new question regarding the seasonality of climate change and how to best prepare for it.
I think, thank you. I think the early warning is a very important investment in many communities. You know, even that is seasonal, if you have early warning, the climate change is affecting even the traditional beliefs about how to deal with the nature. People in many communities knew when will be extreme weather and where they have to move, how they can safeguard food and so on. But the change of climate is really changing all the dynamic what people really had for many years in terms of relationship with the weather and so on. So there's also a need for new knowledge, even from the community, how to deal with those new events. But I think if I look more on the work that we've been doing here and look for the country like Mozambique, where extreme poverty, what is really as a huge problem is that because of poverty, land is the only thing that women can have. So if you lose land, you lose everything. So and today, even that is extreme weather, women know if she loses that land, she will not go back. For many reasons, she will not go back. She'll have to start again. So it's a lot of work that we need to do, and also on preventing women of losing the income that the land is bringing. So you have to replace with something else. And what is this? I think today is the discussion about what can we do to make sure that women will have an income, and to move from those areas that are really keen to extreme weather events, to find regions or where communities where she could be safe. But it's not easy because it's very expensive to land and where thing. And there's a power, as I said, the gender inequality, where women have less power on decision-making body about access to land and resources. So it's still a lot of work to be done, and really exchange that architecture of power at community and resources to make sure that women can really be part of the decision-making, to make sure that they can protect themselves, they can protect the right to land. Because even after weather events, climate event, they lose everything. Even the land that was poor land, but the only thing they had, they lose. Now, if you lose the land, and you back to extremely poverty, and there's no other way on that. So I think we need to be more. We have to understand the complexity of economics of gender imbalance and so on, and really respond to that as in a complex way. Because it's not enough to say, okay, we're just providing commodities, even if we not empower that they can have an economic income to make sure they can secure their land, they can secure the continued access to healthcare. That's really a difficult situation. And I think community have workers, yes, they're extremely doing important work in communities. They're the only ones who stay there because they're part of the community to respond, to assist, and so on. But as I said, those countries like Mozambique, the commodity, the stock out of the medicine is huge. The experience of the stock out. There's no enough commodity around the world to access to women, even on the country where there's no climate events. So, so we need to make sure that we have those resources available at facility level or at community to make sure that they can keep some, they can make sure they have extra kits so they can distribute during extreme weather. Thank you.
Thank you, George. So I think we have time for at least one more question. We know that low-income countries as a whole are disproportionately impacted by climate change. What is the responsibility of high-income countries to help mitigate the impacts of climate change and extreme weather events in low-income countries? Does anybody want to tackle that very large and difficult, complex problem?
Yeah, yeah, George, you want to go first?
Yeah, I would be very far with that. I mean, there's a lot of discussion about how you keep your commitment, and how high-income can't keep the commitment. I think that is one of the difficult questions. Right now, we see the commitment are done, but the really action is not happening. And this it's something that we need to change. So people are feeling that the promise are not really happening. And that you need really to keep even the promise accountable, even the, a promise to the promise. So we need to work on that on that regard to make the commitments and also make sure that the commitment have been met by high income countries. And also, I think we should. I think today, many years ago, people will talk about climate change about glaciers melting, and even the still it's an important result of climate change. But also, there's a women being impact, and it's not coming in a discussion in many international conferences and about climate change. So we don't see the face of the people in need are being impacted by the climate change. I think that it's something that I think we need to have more women face on those debates, on those big stages, and on those events for commitments. Thank you.
Talib, I know you had some thoughts here.
Yeah, I was thinking in terms of the issues of maternal neonatal child health related to climate change are just symptoms. But where is the root cause? I mean, root cause is to really address the disparities, inequalities across the countries and within countries, between high income and low income countries. We can see, as Sky was referring to, disparities within US. And we have seen that even in countries like Pakistan, there are disparities within different segments of the population, between rural and urban. So I think there are gross disparities which relate to climate change. And when the flood hit Pakistan, the Foreign Minister of Pakistan, Mr. Bilawal Bhutto Zardari, talked about the climate justice. And the same thing was echoed by the UN General Secretary, who was visiting the flood-affected areas, and Angela Jolie, who was also visiting there. So they talked about the climate justice. So I think that is very important and should be the core discussion point at the COP27, that how we are going to make our commitments, because it's, after all, this entire globe, we own it. We all, entire humankind, should safeguard it and should protect it, irrespective of the country, race, religion. We all need to work together to address this issue of fossil fuel burning and reducing the percentage of carbon in the environment, and making some commitments. We know that there is a Paris Agreement, there is COP27 is happening. So maybe the commitments for 2030, commitments for 2050. So I think the important thing is how we are going to monitor, and how we are going to look at the data, how we are going to set the indicators so that we could achieve sustainable development goals. We achieve the global targets. Even in terms of family planning, we are having FP International Conference on Family Planning from 14th of November to 17. So there will be a lot of discussion over there.
Thank you, Talib. And I'm sorry we have to cut you off there, Talib. We just have a couple of minutes left. Neela, I just want to make sure that you have a chance to comment if you wanted to respond to any of the questions in the last few seconds before we close out the webinar.
Thank you, Paulina. Yes, I do agree with colleagues here, how to collaborate, I mean, between the rich country and the developing countries like Indonesia, that we have to responsible together for this urgency issue. Yeah, we need like in-depth research to develop some evidence and bring the evidence to the global dialogue that this is the urgent, how people impacted by the climate change in many dimensions, in all the dimensions of the life, especially for women and children. So I think that's it.
Thank you, Neela. An apt way to close out the webinar for us. So I wanted to thank the panel very much for all of your expertise on today's session. It was really interesting. I learned a couple of things myself in the field of maternal and child health, and of course the regional perspectives and what's being done on the research front are really good for us to be aware of. I wanted to thank the Wilson Center and UNFPA once again for facilitating the event, and let the audience know that there will be a recording available on the Wilson Center event page, either by the end of today or tomorrow morning, where you can review or share today's event. There's also going to be a summary of the event on the .mom column on the Wilson blog called the New Security Beat. Thank you again to all of our speakers, and thank you to the audience for tuning in today. It was a pleasure to join you today in this important conversation. Thank you.
Thank you.